Yes, good morning, everybody. And if you can show the slides, case number 1, live case. So you see myself here, and I have Parasuram, my fellow and now associate who's doing structural intervention here, and fellow who is... Okay, case number 1. So this is a 79-year-old male with the known risk factors, as you see, hyperlipidemia, hypertension, diabetes, and hypothyroidism. Had known, positive stress, ongoing angina, was referred for cath few months back. 3-vessel disease and had a EF of 32. You see the SAQ score of 77. And his hemoglobin A1C was around 7. Was on good medical therapy even at then. 3-vessel disease, diabetic, was taken out of the room, seen by the surgeon, but between the surgeon and the physician, his mobility is not the best. He was very reluctant to go for open heart surgery. So we did do his vessel, which was circumflex, as well as the RCA. After that, at that time also we had to use Impella assisted PCI was done, but today he's here for the remaining vessel PCI, which is a LAD diagonal, moderate complex, the calcium based on the angiogram. So I'm just going to show you this is the right coronary artery. EDP was there about 22 today. And this is where we are with his left system. We'll barely see any flow in his LAD. The circumflex, if you see you can see the strand. We'll take a caudal picture later on. Actually, his LAD has the flow actually has diminished ever since if you see this previous angiography. So you have a D1, but complex bifurcation. If you see some calcium at the origin of the D2, but his second diagonal as well as LAD are equally involved. So this is where we are with this case. And for imaging, we will have a key if we have, whenever we need the imaging. So our plan was that we are going to wire, and since there is moderate calcium, the consideration is, should we even consider rota of D2? The way I think is that the wire will likely go into the diagonal. LAD may be difficult to wire.
So as you begin wiring, if you don't mind, because we have this great panel, especially the PI of the protected PCI here, Dr. Stone. Greg, is this an appropriate patient for protection?
Well, that's what we're going to find out. As you alluded to, we are randomizing 1,252 patients in Protect 4.
And you're almost done, right?
We have 4 more patients to randomize, so we're going to be done within the week. And hopefully then about a year from now, we'll be presenting the results. So, and this would be a perfect Protect 4 patient. The EF's 32%. We're in a phase right now where we're actually only at the end enrolling patients less than 30% to get even higher risk patients. And Mount Sinai is actually leading enrollment, so I'm sure that's why this patient wasn't randomized. But this is a perfect case for Protect 4, and we'll learn.
Great. Samir Kapadia is in Cleveland Clinic. Would this patient be protected?
Most of the time, they again depends on the clinical situation. But if the LVDP is 22 and if the patient is not having heart failure symptoms, and the fact that this is almost a total 1.25 LAD, some people would say that this is possible to do if the RCA and circumflex are revascularized without protection. So it is, I think, a clinical decision more so than the anatomical decision at this point. But if you need more complex, this is a very involved
complex,
PCI.
Isn't it? And difficult. And it just, you heard her, she's calling for a rotational atherectomy.
Exactly. If you need all these things, then protection would be
Let me just
common.
ask, Anu, can you just tell us your wire choices? And I see just to give us your technique on how, what your thoughts are here.
We predicted that even when we were discussing with the fellow that the wire likely will go to D2. Wiring LED will be difficult. Going back to the discussion by Greg, Samir Kapadia, that why would we need a protection here? So if you see here, the wire went easily. I used a fielder wire, fielder fine cross. So polymer jacketed wire, whether it is fielder, whisper, whatever people are comfortable with, that is something that you will use. Good old way of seeing calcium, just by angiography, tramp track calcium. This is a case where you will have no time because the flow, LED actually flow already shut down as soon as we wired the diagonal, which we predicted.
Are there
So based
SCT
on
wave
that,
changes? You're seeing any changes as you wired, as you said that you feel like the LED is now completely closed?
Can we show the hemodynamics in the side? Yeah.
No changes. Okay, great.
No changes yet. I mean, to begin with, this patient, I think, may be well compensated. Though we did not see any collaterals, but chronically occluded vessels. So you see the tramp track calcium, so we will do the rotational atherectomy. The question will be what size burr, because now everything is based on imaging, but I say, based on our experience, what I will call as EYE, which is EYE bus, where use your eyes to understand. Likely we will use a 1.25 burr, not a 1.5 burr, just because the way the diagonal is taking off. You have to make that turn. So we will go with a 1.25 burr.
I just wonder, we have Bruno Scheller and Jazz. I know Jazz uses a lot of adjunct devices, but you're both also quite excited about drug-coated balloons. Would you consider a drug-coated balloon to this diagonal and then do the rest of the work down the LAD? Or are you open to how Dr. Kinney is proceeding? Because she's going right in with a rotational atherectomy. So why don't we start with you, Bruno, and then I'll ask Jazz.
So I think the strategy for calcium modification is perfect. We will do the same, the situation. And the decision, what we do at the end of the day, depends on how successful you are with your calcium modification. So for me, at this time of the procedure is totally open what I will end with. Perfect.
Jazz, any comments?
Yeah, no, I think two things. One, wiring, you just take whatever wire you can because don't persist on doing bifurcation wiring because you're never gonna wire it. So I think take the diagonal. I think, it depends on really how you modify the plaque, because if you get a good plaque modification, then I think doing drug-coated balloon for one of the branches, giving vasodilator, see how the artery opens up, is then how you're going to decide. But I think plaque modification is very, very important step. You won't know, if you try to do balloons, you'll crack everything, and I don't think drug-coated balloons will work here. So I think this is a good step.
But also the more important thing is that rotational atherectomy is going to help you to wire the LAD too, because it won't close the LAD, and this is a great strategy. That you just do the rotational atherectomy of the diagonal, and then you'll be able to see the LAD and wire it better. If you balloon it, it is going to be a disaster that you will not be able to wire the LAD.
And you can see it's not a soft plaque,
Yeah,
so that 125 is not going. So
Yeah, let's see, Dr. Kinney. I know that she's worried about that takeoff into that diag, and maybe is going slowly. The heart rate has picked up a little bit, I think. Anu, do you want to tell us what's happening there?
Yeah, so we took a 1.25 bar just because the diagonal takeoff, and I just did a dry cine. You see that? Just want to see if there is any kind of wire bias. There is some wire bias, so we just have to be very cautious, gentle. The entire case is doing rotational atherectomy into that diagonal. So I think I agree with the points discussed so far. So
yeah, I see how you're pecking very slowly.
Slow pecking motion, yes.
Dipti,
so now
any thoughts,
you will
Dipti?
hear that go a little bit higher speed. 150, yeah, a little bit higher, 155, yeah.
Dipti?
No, I like the fact that we're using 1.25, and I agree that you have to go very, very slowly in this area.
Yeah, and I wonder, would IVL be a possibility here when you see these kinds of takeoffs? Anyone on the panel might have chosen an IVL.
It won't cross,
there we go. It
Roxana.
crossed.
It will
It's
never
crossed.
cross because it's a pretty much a
The
functional
IVL would
CTO.
not.
You would have to balloon it and then do it, so you'll crack it. I think, upfront atherectomy is probably the way to go.
Yeah, okay, good.
Yeah, I mean, a roto IVL
So,
strategy isn't unreasonable.
okay,
but
Dinah?
Yeah, the balloon
Okay,
unlikely
ready?
to cross.
Yeah,
Okay,
especially
no,
if
no,
you
no, no,
can-
no, I want to go forward, yeah, stop.
Okay.
Yeah,
Especially if you can wire that LED after this.
Yeah.
The other point
Yeah.
I make is that it's, once you get this open with some sort of vessel preparation strategy such as this, it is important to ultimately do intravascular imaging.
Oh,
I
yeah.
think
This
right
vessel
now.
looks so small
Oh,
and
I'm
so
sure.
diffusely
Yeah.
diseased, but we know the LED is a lot bigger than this.
Yeah, I'm sure she's planning on doing that. I know she has the entire imaging
stop
team.
here, right?
Yeah.
I think we don't need to go there.
How fast do you use the burst speed these days? This is because a lot of people have different variations.
I think she picked it up right around when it wasn't.
Yeah,
So where did you
yeah,
go?
because we-
Anu, do you
So
want to
what
tell us
happened
your
is,
burst
yeah,
speed?
the Rota Pro comes fixed at 150. So I increased this to 155 once, Now, you see the second lesion also, we are having a difficulty in the diagonal. So that is where we have to be cautious. Diagonal at that level, risk of perforation. So I'm wondering, we have done a, partial, maybe a few millimeters into that lesion, that do we just leave it or do go ahead and complete it? So we went higher speed. So with 125, we do our rotational atherectomy at 150, 160, not higher than that, but I know there are Japanese papers, Europeans who try to use it higher speed, go up to 170, 180. We don't like to do that speed. But I don't know, ask, people in the panel if that is what they would do.
Well, no, I was just
Go.
laughing here because I'm sitting next to Samir Kapadia. It made me think of Patrick Whitlow.
Yeah.
The late
It's
great-
hard to
I
hear,
still,
Dr.
I still
Botts.
use
Can you make
180
sure
many
those-
times. So I like 180 because this kind of, it spins faster and it is less riskier than going a little slower, especially in smaller arteries.
You went up 165, 170.
Yeah,
okay.
170. you can-
Okay.
Davide
We're
Capodanno,
going
I
up.
haven't heard from you. What are your thoughts
Okay,
here
no.
with this
Okay, wait,
distal?
stop that.
What do you think?
Let's
Dr.
do
Kinney is
China.
very cautious about that distal lesion in that second
Ready?
diac.
But I'm
And
sure she
I'd be
will
really
make
cautious
one of the
too. I wouldn't-
considerations
Why
I
don't
want
we
to
feel
make is
obligated to go very distal.
Okay, good.
I think you just want to clear a path to make sure you can enter the LAD, and I wouldn't necessarily go much further. I was, reflecting probably because I'm sitting next to Dr. Kapadia here, and our late great mentor, Pat Whitlow, who used to do a lot of roto. I mean, he would typically with the 125 go to 180, 180,000 RPMs, and sometimes, there's some advantage to that. Of course, you get more platelet activation, more, distal embolization, so one does need to be cautious.
come
But
out.
sometimes it does help the cause to go to the 180.
Davide Capodanno?
No, I just want to echo and mention that in Illumium 4, one of the positive interactions
good.
was calcified lesions, where in this subgroup, particularly OCT, was very meaningful. So once there is the bulking here, hopefully we will be able also to see some imaging to guide further the procedure.
Yeah, and I'm certain that Dr. Kinney is planning on imaging. Okay, Dr. Kinney, tell us we see you're taking your rota out.
Yeah.
What's next?
We could not complete that second. We already
Yeah.
finished 2 minutes, 30 seconds of burring. Now the question is, should we have gone to 190? I did not.
Yeah.
Okay, now give me the fielder wire. So we'll try to wire the diagonal. Question is, we did not do the complete second lesion of the diagonal, but we probably did at least half of it. Hopefully, we should be able to dilate it, okay? And
Yeah.
let us see how the vessel looks.
Okay, we still see flow in the LAD, which is good.
Yeah, so
And,
we see some flow in the LED.
It
So
looks
now
like
the
you've had a
question is
little bit
what
of
wire,
impact.
right?
Let's see. Let's see what happens with devices. And it's interesting because there's,
Give the fine cross. Or you want the
that
fielder in the
lesion is
diag?
sitting
Okay.
on another
No,
side branch
no,
up
no.
there.
Let me fine cross.
So,
Fine cross, yeah.
It
And
looks,
the
like,
fielder
looks
here.
like a dual LED
Yeah.
system. LED looks intramyocardial. And diagonal looks like it goes to the apex also. I think now you'll be able to wire the LED and probably balloon the distal lesion too. I think you've done enough modification of the bifurcation.
Yep.
Yeah, I agree with Jazz. The way the wire is in the diagonal, it has given us, okay, well, hold it there. So what I'm going to do is I'm taking a fielder only because I'm taking a fine cross and a fielder to wire the diagonal. Reason is we may need a different kind of a wire to get into the LAD. So right here, right?
Yeah.
Someday. There's the same fielder wire.
There you go.
There.
I know, it looks that way. If not,
No, I
Okay.
think you're going to get it.
Yeah, it actually
Maybe a little
starts,
more proximal.
yeah, more proximal than we think it is.
okay, you know what you do?
Thing.
We go like this. Go. Okay, look at the way it is taking off.
Yeah,
Yeah.
it's really,
Oh, actually, it's more distal
Yeah.
and it's got a
Yeah.
retrograde.
Yeah, this might be
entry.
a
You
case.
Then
might
I have
need
to
a
change the
harder-
way the
harder
fielder
wire.
take off is
For-
number one, or
It's almost
I
like
go
a
to a
CTO.
miracle 3. You want to give me a miracle
Yeah,
3?
it-
Some
it-
people may say take the Gaia, make a little extra curve and then try it.
Yeah, it might
Maybe
be a
quickly.
case for angioplasty and supercross because you don't have
We
room
have
to play.
Supercross ready actually.
Yeah,
yeah,
What
and
Jazz is saying is that you dilate the diagonal, and then, dilate the LED at the level of the diagonal and use a supercross to get into the LED. So I'm taking Miracle 3 with the
that's what I was. I
short
thought
curve
maybe.
and see if I can
It's
get into
almost
the
like a
LED. Otherwise,
CTO. If not, it is. It looks like a,
yeah.
to
And also
occluded.
it's calcified, so as soon as you
Calcified.
hook it, your wire will keep on prolapsing in the diagonal. You probably won't do it, so you probably need a microcatheter that hooks into that ostium. But,
Yeah, the Miracle 3 is a nice choice here because you need that extra support to control the wire tip. You got to go retrograde and then go another 180 degrees back anterior. But it may need to be sharper than that.
Something tells me you might have to
I think
do
yeah,
the
someday.
diag.
Yeah,
Okay, done.
it needs to be
Yeah.
even a little,
No,
I
I
think,
think
more
it's
angulated. It's
okay.
tough.
Get me Gaia and have a fighter ready. Gaia 2.
So tell us, Dr. Kinney, what you're thinking. So with the Gaia, a better
So
manipulation.
Gaia, what I have is tapered. So if we can show all these wires in the side, Andrew is there. So if you see here, it's tapered, hydrophilic tip. It's one of the, comes from Asahi CTO wires. X-strand is the technology that is made. That is why 1-to-1 torque is very good. They show it? Yes. Can you see? Can you see
Yeah,
it?
we see it. Yep.
Yes,
we
yeah,
see
yeah, a
it.
little curve comes, but I'm going
Yeah.
to change the curve a little bit because you need a tapered tip. The other wire that may be able to get in is a fighter wire made by Boston Scientific, again tapered tip. It becomes almost 0.008 at the tip. And that's what you need to get into that little micro channel of the LED. So this
Okay,
kind of a
let's see.
curve, if it
Let's
gets
see what
in,
you're
let's
going to
see.
do.
Anu, I mean, even Fielder XTA.
Yeah, Fielder XT, yes, yes.
Yeah, I think I
Fielder XT
I
is
would
also
probably go, because these wires will hook and
Okay,
it'll
get us a
it
Fielder
can go
XT.
in the false channel. So, I would probably start with the Fielder and try to hook that and see slides through. Because once you get into this channel, these wires get there, you're going to go into false channel, unfortunately. So that might be the
Okay,
way to do it, but
Fielder XT or the reason the Fielder XT may not work, Jazz, because of the calcium and
yeah, it's
I also like your idea of dilating that diagonal and maybe,
we may have to do that. Yeah.
Yeah.
yeah, just do supercross. I think that
and
might be
doing the
way.
supercross. I mean, that might
No, a
be a way.
supercross, if you need supercross, you need to dilate it because you need a little space for that supercross curve to stay in the LED.
Yeah.
Okay, let's dilate. What's the balloon we have ready there?
2.5.
But then I have to go with the,
It's a very,
no, got to go with a fielder wire.
Yeah.
Get a fielder wire, right?
Yep.
Might even be a sharper bend than you've got. A little
Yeah.
longer, a little sharper.
100%. A sharp bend and calcium.
This.
Yeah, a bad combination.
Yes.
All right.
Interventionalist enemy, calcium.
So,
the key is
Okay,
you're
so
not
we
even,
are, what
you're
I'll
not
do is
even
I will
hooking it.
wire side
That's
by
the
side
problem.
into the diag because it's a rotor wire in the
think you have to
diagonal. Let's
dilate
dilate at that level
to
and then,
change the
then we see if we can wire the LAD. Keep the fine cross ready again for the LED.
So we'll watch this, but let us know if the other lab is ready because we only have 37 minutes. I know we got a couple of cases.
I don't know if Dr. Sharma is back.
Okay.
Is he back?
No, he's been there, I think. So let's see.
Okay, they're apparently ready also.
They're ready? Okay, let's watch this and see what happens after you're done.
No, I will. I want to dilate and let's see if we can cross LED
Yeah, that
live.
would be
Then
really
we go
cool
there.
to watch, and I think it's a huge lesson for the audience here. They're all watching very captively.
What size bar is, balloon? No. Get us a 2.5? What do you think? 3.0? 2.5.
It's a good idea to
make
put
it
the
like that.
second wire in there because, if you dilate this and you dissect it, you'll probably never get in. So that wire is there. So once you balloon it, you pull that wire and you are in the true channel. So that's actually a very smart move. So whenever you do that, like a suicide maneuver for side branch, always have your second wire in there because I think that's a very, very important step. So that's great.
Instead of dilating, would another option be a larger burr at the origin of the LAD, which would be less likely to close the LAD?
Yeah, not a bad idea. Larger burr right there.
Even a
Just
175
yeah.
just to the origin of the LAD.
Yeah, and I think, ideally 175, but maybe we have to do 1.5, but we're already going with the balloon. That's an excellent idea, number one. Number two, somebody may tell us image and do IVL, but IVL can give rise to, dissection. Let's see now here, right?
Yeah.
That's what I'll call
Does
it.
the balloon go
Okay,
down to that distal? Does it cross? Just to get an idea.
I don't want to get there right now. If it dissects, then we'll be just focusing on the, okay? Open it.
Though I think
No, just to see
Roxanne,
if
you
it
meant as a
crosses.
test, yeah.
Yeah, yielded pretty good.
You may need a 2 there. Further
Yeah.
down.
Yeah, I just want to know if it
No,
crosses.
it's not even going. Not even going. Okay.
Yeah, that's what I was,
Okay, go up.
it's like a fresh balloon.
Yeah,
Okay.
okay, down. Now get the fine cross again and,
Watch your distal wire there with your,
yes.
Watch your wire, watch your guide.
LED. LED is a very retroflex band.
okay.
You want the fine cross the side. I'm taking the rotor wire out of the diagonal and take a picture. Let us see what we have done to the LED. Is it there still?
It'll be there.
Yeah, okay, go.
See?
Okay. Give the fine cross again. Okay.
You
they
might
want,
need to go a little bit more cranial just to lift off that. I think it's hard to see where is that hook. So,
Yeah, it's right at
We may be able to get
where
in
the
now. The
first
fine cross
diagonal
and what?
starts right after that.
Get the fielder itself and then
bad
once we
angle.
reach there, we'll change it. You have a fielder
angle is
or
tough.
get
The
us a
vessel's a
fielder?
little larger
Okay, then get
now,
us a fielder
Now
XT
you may
then.
need even a longer bend.
okay.
No. We're going to try wiring diagonal for a little while, then you can go to the other side.
Either Supercross or the Recross catheter or Suzuki, you put it down there and then put it side branch. Those actually are amazing to wire because you have support right there. So I would either put Suzuki, Recross or a Supercross. Those things actually don't need too much lumen. So if I take one of those dual lumen catheters and put it next to the tank, I think the fielder will go in the LAD. So that might be the way to go, Anu.
We actually have the dual lumen catheter. Let's try with the fine full back. Good, fine cross. And then,
Let's see what
I don't think we
happens now.
carry Suzuki. Twin pass is what we carry.
You have the twin pass,
This
right?
is a, yeah.
Okay. So you're coming very close, and then you'll put that.
Now die here. Is that what it is?
Good, you definitely got more length on the bend. That's good.
Yes. Now the miracle may be able to do it.
Or the Gaia.
Yeah.
Yeah. It's just not hooking. Oh. Okay.
There it is.
Ah,
That's it.
woo! Well
Okay,
done.
go to room 3.
Okay,
We're
go
just
into
going
room
to
3.
dilate and show you.
But just tell me, what are you gonna do in that diagram? You're gonna just try to, I mean, in the LAD, just try to dilate,
No,
AK?
no. Yeah, we'll put a star. Our goal was
Okay.
to do
I'm going.
bifurcation
Let's go to
stenting,
doc.
but we will see what we can do.
Okay,
We
okay.
have the 300 run through, right? No, I know trial is one, and what we see in Mount Sinai is a different, okay? This calcium, I'm telling you, you need special devices to open the calcium that we find here. So LAD we wired, right? So we tried to balloon, but nothing is getting into the LAD. No wire. So we are trying to do rotational atherectomy into the LAD now.
Okay. So you
So only
got the
thing is, people
rotational?
will now tell me that why you're doing rotational atherectomy, do imaging, maybe do IVL, but since the
No, but
balloon
you
is
can't
not
cross
crossing,
anything. Nothing is
yeah,
crossing,
so
right?
nothing you can do.
So
Good.
that's
Okay,
it, but
good.
it's the same
No,
burr,
no, that's
the same
one thing.
1.25
I know
burr?
you were discussing about imaging, but let us try to do here. No, go magnify. This is low mag. Yeah, good. Okay.
So what, is the same burr
So-
size, or did you go up higher?
No,
it's
we went
1.25.
higher, 1.5. Remember earlier, Greg was discussing also that why don't we go higher burr size in the LAD? So this is where we are, where nothing was making a turn.
Okay, you're making progress. And what's your speed there? Is it 170?
155 now, going up to 160. Asif is listening. Yeah.
Yeah, and with the 125
So the pressure is,
in particular,
you can see the hemodynamics as we are doing it,
Yeah.
right?
yeah.
A little bit of EKG changes we are beginning to see. Yeah.
There you go. With that 125 in particular, you got to go so slow and be careful not to get it stuck.
Is this a 125 or a 15?
1.5. This is a
the
1.5.
I think it's a
1.5.
1.5.
This is the 1.5.
Why the pressure is like that, guys? Why is it all over the place?
So
Huh?
the tracing looks kind of funny, but I don't know why that is.
Yeah.
It's probably 1.5 burr, and the guide is not
Here we go.
coaxial, so it's probably changing the
No, no,
pressure.
no.
Once the burr comes out, it'll probably be okay.
Okay, good. You made a little explain.
Okay,
good.
you got
At
it
least
now.
here we were able to get a lumen, yes. Okay, that we were able
Okay.
to do it. Okay, so get me a fielder and a run through. So we'll get the fielder into the diagonal and run through. Into the LAD.
Okay,
So we did try dilating, you were there when you saw us dilating the LAD and diagonal, right?
mm-hmm.
We're going to take a picture now. Yeah, it's done. Okay, take a minute, right?
Yep.
This is why maybe the guide. Okay, good.
Like your pressure's good.
Yes. Wow. Now everything opened
Now
up.
we have
I think
an
we needed that
artery.
1.5 bar.
See,
Yeah.
I was more worried about that lesion than Samin's lesion, because Samin's lesion had the wire bias, and you know that was the straight path. This was more concerning, but that's a great result.
So Now you're going to dilate and then image, or when are we going to see some imaging here today?
No, yeah, yes, let's just wire it and then decide, because
The
I think
imaging-
we call it
imaging ain't
artery in
gonna go.
pieces.
Yeah, you don't
you're
want
right.
to mess around now. You angioplasty.
Balloon
then you
is
image,
not
yeah.
going to go, means imaging catheter is not going to go, that's number one, and
Well,
arteries
you
in
just did
pieces, we
Rhoda,
need to
so
dilate
let's
and
see after
stabilize.
I
your
actually think
balloon.
I think you could put a long 2.5 balloon in, get this whole thing open, and then image to find
Yeah,
out
that's right.
where you're going to put the distal stent and how large you're going to expand it.
Yeah, no, that's what she's doing. I think that's
That's
probably
what
right.
I'm sure
Definitely.
that's what she's doing, but we want to make sure
Yeah,
we get to it.
That's a great result, though.
Yeah.
Anu, nice job.
Yeah, thank you. And now get us the balloons, at least what, 2.5?
Yeah, 2.520 we have.
20 we have, right? Get it.
I
So
mean, if we
now,
were in Italy,
the
maybe
dissected
Davide-
vessel,
Dav-
let us try to get in the lumen with the entire vessel that's dissected, yes.
If we were in Italy and Antonio was there, I think, Davide, you want to say what he would do? He'd probably put a bunch of drug-coated balloons there. Would that be wrong? Davide, Capodanno?
No, you know, what he's now saying is that it's not the DCB per se, but the strategy. So DCB plus bailout
Yeah.
scaffold is these days, rather than DS, but
Fielder?
with Antonio.
So we need data
Yeah,
on
but
that.
if you do that,
but-
you better do it without imaging.
Take the
Because
rotor
if you image this, there's no way you're going to do anything but stent it.
Yeah.
Bruno?
Yeah.
Okay,
but it's-
2.5 balloon, so we'll do it. The diagonal we've never dilated.
Okay.
You have to do lesion
but I-
prep. You have to dilate all these things because, you know, we are all
Yeah, that's
about
what she's
drug-coated
gonna do.
balloon, drug-coated balloon, but luminal gain is
Yeah,
still
we
the
got
most
that.
important
We
thing.
got that. I just want to hear, I've got all these experts here from around the world. So Bruno,
So if
what
if
do you think
if you do
about that concept?
If you do simple soft bifurcations, I think you do not need necessarily imaging. But in this highly calcified lesion, you should do imaging to see what you're doing.
No, that they
Okay,
will.
balloon, quickly.
Good.
You know,
So,
an important bifurcation and long calcified lesions. I mean, this is the sweet spot for intravascular imaging.
both imaging and I think.
Okay, but everybody
the
agrees we
future-
are going to do the balloon and then we get the
Yes.
IVUS ready? We have?
Yes.
Okay.
Yeah, we have.
So we're going to get into the LAD. Hold the wire for the LAD, yes. Leave it. IVUS is there?
Yes.
Get the IVUS. Yeah.
Samir
we do that.
Kapadia, you're running a huge health center at
Look.
the Cleveland Clinic on cardiology. Now, you think we're using too many things here, too many devices with this? Should this patient have gone to, this patient has had previous bypass, I think, but
No, it did have bypass, but yeah, no, I don't think, this
Guide.
imaging is necessary because it is going to actually save the cost at some point.
Done.
But I do agree that we are using a lot of devices in
Come on.
general, because,
but if they
Impella,
wanted to use a drug-coated balloon in combination, would you even allow that? Because we heard from Sunil, he's got it locked up in the cabinets. He's not letting people anywhere close to it unless the patient is in a
Okay,
trial.
done.
Is that what's happening at the Cleveland Clinic too?
Not
Dr.
really,
Kapadia?
we are still using
the
it.
diag,
I agree
get
that
me a
it is
2O balloon to the diag.
financially very difficult,
Right, 2
but still
femoral
we are
bone, no?
using it. We are not locking it up yet.
All right. So, Dr. Kinney, you've dilated the LA, it looked like the LAD, right, first, or I don't
Yes.
know. Yeah. And now, you're going to do the diag?
Now
or you
we
wanna
will go to the
image?
diag, but to the diag, distally, remember our
Yeah, you had some
ball
issues.
did not cross. Yeah, so I'm going to go with the 2O balloon.
Yeah, go a little
Dilate
bit.
there and then
yeah.
IVUS is ready for the LAD. Yeah.
Okay,
And then we can
excellent.
decide, did we do enough for debulking or do we still prox LAD, we need anything more?
Okay.
Yeah, that diagonal
And
will
we
be hard
actually
to
are the
cross.
one, we have the algorithm for management of calcium that came out in, branch of JAMA cardiology, as well as then we have, which we presented in ESC last year,
Yep.
management of, calcific nodule, because that is where all the discussion is yes, we do imaging, we see things, and then which device do we use? COP.
It looks like your balloon went, so you did do something there.
Yeah, no, but way further down.
Not
Yeah,
the
it didn't go
lesion.
more
Did you go
distal.
all the way
the lesion
down?
is
Is it
distal.
More
distal?
distal is where the question is.
Yeah, distal. I may need a new balloon, I think. This is not making
So 1.5,
anything.
probably 1.5.
I mean, if it really is that hard and nothing is going at this stage, I will leave it alone because we got to focus on, look at, everything came out,
Yeah.
telling us that there is still so much calcium. Can you do the imaging of the
LED.
LED then? The other thing is there could be an interaction between the Impella and the guide.
That's what it looks like to me, actually.
Yeah.
I kept seeing that throughout the, and that's why maybe even I see it. There's like a bend the way the
Impella is
guide and the
sitting.
Impella is sitting.
The
Yeah,
interaction between the Impella and the guide is.
Yeah.
it's not in the right spot. See, it's going behind and then coming forward.
Right.
Yeah.
Yeah.
Okay.
Okay, let's at least
You
image
guys
the
have
LED.
4
Come,
minutes,
then
and
I'll wire
we
that
gotta
up.
see the other case and what's happening in the other room. So maybe, should we do?
Okay,
What
go
do
there.
you wanna
Yeah,
do?
yeah.
Can I go to the other room, or are you gonna?
Yes, yes,
Because
yes.
you're gonna cross
Well,
that diag
no, you
again?
want to see the LED imaging?
I do,
So then we
yes,
can make a
please.
decision, yes.
So Anu, do you prefer IVUS or OCT in this situation, or you don't care? Either one?
So, interesting, of course, OCT is the best because two things. The thickness of the calcium, and to really understand, have we done enough debulking? OCT is the issue with OCT is say multiple runs without dye. I know people are doing without dye-less, but without dye, you don't see it well. So if you need multiple runs, and especially then left main is involved here, left main is not involved, IVUS is probably the best, yeah.
And do you have a preference
If you want to
of,
see the cuts, if the calcium modification has happened well, you definitely need OCT.
and which kind of IVUS device do you use preferentially?
Looks like the Boston.
We go and we like to use 4 millimeter. Remember, it comes in 8 millimeter to 1 millimeter. So we do it in between 4 millimeter.
Okay, start to back. It's like a little bit myocardial breach. Yeah, some hematoma here.
Hematoma?
Yeah, but so far not much calcium.
Yeah.
Here a little bit. Yeah, here's calcium.
So now tell us at the proximal LED, right after the diag.
Revelation.
Yeah, 360 degree.
Yeah, prox LED is 360 calcium. Yeah, I will stop it. Yep. So I will quickly check. So I will show you. This is like a 2.1 vessel, very small vessel.
We use 2.5 balloon.
Here looks like 3 o'clock. Here is a hematoma here.
Okay.
Tissue cover here. So this surrounding zone is gonna be like a 2.2 vessel. Then, yeah, mid to distal, yeah, as I told you, there's not much calcium actually. But around here, the calcium start.
But it looks
Then-
like you've ablated the calcium quite nicely.
Yeah,
There's
yeah, well,
lots of
coming to the
cracks there.
proximal LED.
This is actually like proximal LED, and a lot of liver ablation, and the surface is like smooth. It's like shaped by the rotor.
Yeah, you saw that reverbs, those reverbs are typical
Yeah.
rota artifact.
Yeah. So
Okay, pull back, come to the proximal.
There was
So
a
I
nice.
Because we need to know, are we okay? Have we done enough in the proximal? So looks like a mid to distal LED, good modification, ready for stenting. Proximal.
Yeah, here's
another point
here's
is-
the question. So
Say in the
there you-
proximal, 360 degree.
yeah, and actually not good landing zone. It's gonna be on the 360 calciums. So maybe the best size might
Do
be.
you see, do you think, I know IVUS is not the best, that you see at 4 o'clock, 5 o'clock, that there is an, you see the calcium plate has been,
I mean, yeah, it might be some dissection. Even
Yeah.
the angel shows some like
I feel
haziness.
like
It
Yeah.
might be some dissection but because of the calcium artifact, we cannot see the behind the calcium any dissection or something.
Yeah.
It looks like some hematoma here. So
come
hematoma in the revelation.
proximally, come proximal,
Yep.
more.
Yep.
Oh, yeah, right there.
I mean, it might be our landing zone.
Yeah, you look at that 4 o'clock. It's a break in the calcium.
Yep.
I think
Or
you've
some
broken it enough
can just
to be
stent
able
it,
to go.
yeah.
Yeah, I would use a larger balloon.
Yeah,
I don't think you, I don't
could
think you
go
need
ahead.
another, it's not that long a
Yeah,
lesion. The
I think
vessel's
you can go
large.
ahead.
And I think you do have one fracture in most of the places.
Okay,
Yes.
So I would
so,
just use,
one
I
fracture
would
is
use,
probably
I would
okay,
use
yeah.
a larger balloon.
so Anybody,
Okay,
I
then
want to go
again
to
the
Dr.
question, Raja
Sharma.
balloon, regular Raja high pressure balloon,
High
or you
pressure,
think you need a
yeah,
cutting
high,
balloon?
high
Cutting
pressure
balloon.
for sure.
Good, so that's where we are. So we said that's the way we'll put a short 8 millimeter stent. You see at least 2 millimeters into the LAD. We deployed. Now look at it. You see at least 4 millimeters, 5 millimeters. You see the roof, it's covered, right? And this is tap technique where the lower portion of the side branch stent is in the main vessel. We have a balloon across before we did that, you see? So that's how we deployed. We pulled back, deployed to make sure it's covered. So either you can leave it like this, means you have to do a kiss and come out. So you'll have a single layer of carina in the LAD. So this is the tap. Tap is that you have stenting the side branch through the main vessel, stenting. But since it was at least 4 to 5 millimeters that was into the main vessel, decided let us crush it, which we did. You see that? Completely crush it. So this is called internal crush. Okay. So at the level of the diagonal, you will now have the LAD stent layer and 2 layers of the diagonal, 3 layers of stent at the level of the ostium. So we have to recross. This is how it looked. Okay. So we have to recross. Kissed. Now this is what a trio looks like. We went up to about 16, 18 atmosphere. If you see there looks like there's a calcium at the upper border of that ostium and not allowing probably the stent to fully expand. Kiss. And now this is where we are final.
Yep, looks very good now. All right.